Hello, everyone, and a very warm welcome to MediByte. Now, as your trusted healthcare professional, I completely get that trying to understand your reproductive health, well, it can sometimes feel a bit like you're trying to decode a giant, complicated medical textbook. But hey, that is exactly why we're here today. In this explainer, we're going to totally strip away all that confusing medical jargon. Instead, we're taking a clear, structured look at ovarian health, specifically zoning in on ovarian cysts and other benign ovarian masses. So if you've ever felt that mysterious little twinge in your lower abdomen and thought, wait, what's going on in there? You are absolutely in the right place. Our goal today is to give you the exact knowledge you need to understand precisely what's happening inside your body.
Okay, let's dive into this. Here's our clinical roadmap for today. We'll start with number 1, functional cysts, before moving right into number 2, benign ovarian tumors. After that, we'll cover number 3, adnexal torsion. And finally, we'll wrap up the whole shebang with numbers 4 and 5, diagnosing pelvic pain and modern treatments.
All right, section 1, functional cysts, the common and harmless. First things first, I really want to normalize this for you. An ovarian cyst, it's literally just a fluid-filled sac that forms in or on an ovary. You see, functional cysts are just a super standard, everyday part of the human reproductive cycle. I know. When patients hear the word cyst or mass, anxiety naturally goes through the roof. But let's look at the second half of that definition. The vast majority of these are completely non-cancerous or benign, and they simply disappear on their own. They're basically just a temporary byproduct of your body doing exactly what it's supposed to do. And to prove just how normal this is, the data shows roughly 33%, that is literally 1 in 3, premenopausal women will develop a cyst. That's a massive portion of the population. It really shows just how incredibly common this baseline condition is. If you're a woman of reproductive age, developing a functional cyst is essentially just a routine feature of your biology. And this brilliantly illustrates the two main types of these everyday functional cysts. First, we have follicular cysts. So every single month, an egg develops inside a tiny fluid-filled cavity called a follicle. Usually, the follicle just releases the egg and shrinks right down. But if it doesn't release the egg, the follicle just keeps filling with fluid, becoming a follicular cyst. Simple, right? Then we have corpus luteum cysts. If the egg is released, that empty follicle transforms into a structure called the corpus luteum. Sometimes fluid or blood can build up inside this leftover structure. Now, the absolutely crucial thing to note here is that corpus luteum cysts can occasionally bleed or even rupture. And if those fluids escape into the abdomen, yeah, that can cause some severe pain. Now, most of these are tiny, like under an inch, but they can occasionally grow larger. Ultimately, though, both types usually just vanish completely on their own after a few weeks. Moving on to section 2, benign ovarian tumors, slow-growing masses. Okay, we're going to shift the tempo slightly here and step up the complexity just a bit. Aside from functional cysts, the ovaries can also develop non-cancerous tumors. Now, these grow slowly and, very importantly, they rarely become cancerous. The really fascinating thing here is where these masses actually come from. Benign teratomas, also known as dermoid cysts, are truly remarkable. They actually develop from all 3 embryonic tissue layers, the germ cell layers. Since all human organs form from these basic tissues, teratomas can actually contain tissues from completely different parts of the body. We're talking nerves, glands, and even skin. It's a slightly bizarre but totally harmless biological quirk. Next up, fibromas. Unlike cysts, these aren't filled with fluid. They're solid masses of connective tissue, usually under 3 inches in diameter and very slow growing. Finally, we have cystadenomas. These are fluid-filled cysts that develop right on the surface of the ovary, and they contain tissue from ovarian glands.
So you're probably wondering, how do you even know if you have one of these? Well, often, you don't. Most of the time, they cause absolutely 0 symptoms. However, you definitely want to keep an eye out for intermittent dull or sharp pelvic pain. Believe it or not, some of these cysts actually produce hormones that disrupt your normal cycle. That can lead to irregular or unusually heavy periods, or even spotting between your periods. For postmenopausal women, they can actually cause unexpected vaginal bleeding. And if a mass, like a fibroma, causes fluid buildup in the abdomen, you might just feel this unexplained sense of pressure or heaviness.
All right, section 3, adnexal torsion, a medical emergency. Now, we're transitioning from those conditions where you can safely kind of just wait and see to a truly critical situation. Adnexal torsion is the twisting of the ovary and sometimes the fallopian tube, interrupting or cutting off the blood supply of these organs. Think about it like this. The ovaries are held in place by ligament-like tissues. If an ovary twists around those tissues, it physically strangles its own blood supply. This is a severe medical emergency.
If the blood flow is cut off for too long, the ovarian tissue can literally die, causing irreversible damage to the organ's function. And this builds into an absolutely undeniable physical warning. This right here is exactly how you tell the difference between a normal cyst and a torsion. A torsion doesn't just feel like a dull, annoying ache. No, it brings sudden, severe pelvic pain, and it's very frequently accompanied by intense nausea and vomiting. Sometimes you might actually get a warning sign first, like intermittent crampy pain in the days or weeks prior. That's caused by the ovary repeatedly twisting and untwisting before getting completely stuck. You're at a higher risk for this if you have enlarged ovaries, large cysts, or if you're using hormones to trigger ovulation for fertility treatments, because those things literally make the ovary heavier and much more prone to flipping over. If you feel this sudden agonizing pain paired with nausea, you need to go straight to the ER. But here is a super surprising fact from the clinical data that everyone really needs to be aware of. While torsion usually happens when there's an existing cyst or tumor making the ovary top-heavy, rarely, a completely normal, healthy ovary can just twist entirely on its own. And statistically speaking, this rare event is actually more likely to happen in children and adolescents. So this is absolutely vital knowledge for parents to keep in mind too.
Section 4, Diagnosing Pelvic Pain. Safely finding the cause.
Okay, let's all take a deep breath and come back to a place of safety and control. So the crucial point is that doctors follow a very specific diagnostic flow to take away the fear of the unknown. First, they conduct a standard pelvic examination, where they can often physically feel a larger mass. Step 2 is the gold standard, the transvaginal ultrasound. Using a small ultrasound device, doctors can get a highly detailed visual map of your ovaries to spot any fluid-filled sacs or solid masses. And step 3 is actually a standard pregnancy test. Now, why would they do that? Because the pain from an ovarian cyst or torsion can feel incredibly similar to an ectopic pregnancy, which is a pregnancy located outside the uterus, and doctors absolutely must rule that out immediately for your safety. Now, if you arrive at the hospital with that sudden severe pain we just talked about, doctors will use a specific, really cool upgrade to the ultrasound called a color Doppler ultrasound. This incredible technology actually visually maps the movement of blood. By just looking at the screen, a doctor can instantly see if blood is actively flowing to the ovary or if the flow has been completely cut off. It is literally the critical tool used to confirm if an ovary is in immediate danger of tissue death due to torsion. And finally, Section 5, Modern Treatments. Next steps, and surgery. So we've identified the mass. Now, how are these conditions actually managed? Let's walk through the clinical protocols. For the vast majority of you listening right now, if your ultrasound shows a simple cyst, meaning just a fluid-filled sac surrounded by thin, smooth tissue, it is incredibly unlikely to be cancerous. The standard medical treatment here is literally just observation. Your doctor will simply ask you to come back periodically for repeat transvaginal ultrasounds, just to ensure the cyst is shrinking or has disappeared completely on its own. Your body does the work, medicine just double-checks it.
But what if you have a solid, benign tumor, like a fibroma, or you're experiencing the emergency of an adnexal torsion? Well, that requires surgery, usually taking one of two main approaches. Laparoscopy is definitely the most common. Doctors make tiny incisions, insert a viewing tube called a laparoscope, and use tiny instruments to do the work. It requires general anesthesia, but the great news is you usually go home the exact same day. However, if the mass is excessively large or complex, doctors must use a laparotomy. This requires a larger abdominal incision so they can directly view the organs. Because it's a bit more invasive, it does require an overnight hospital stay and a little more recovery time. The choice strictly depends on the size and the severity of the growth.
Regardless of the surgical method, though, a surgeon goes into the operating room with a very strict hierarchy of objectives. Number 1, if there is a torsion, their absolute immediate goal is to physically untwist the ovary to restore blood flow. Number 2, if there is a mass, they'll perform a cystectomy, attempting to meticulously remove only the cyst while leaving all the healthy ovarian tissue completely intact. You see, the primary goal of modern gynecology is always to preserve the ovary and your hormonal function whenever it's technically feasible. Number 3 is the absolute last resort, an oophorectomy, which is the complete removal of the ovary. This is only done if the tissue has already died from a prolonged torsion or if the tumor is solid, massive, or completely inseparable from the healthy tissue. We have covered quite the spectrum today, haven't we? From the completely normal biological events of functional cysts all the way to the urgent medical crisis of an adnexal torsion. So I want to leave you with this final provocative thought. Are you listening closely to the difference between a dull ache and a sudden, severe warning from your body?
Understanding exactly how to interpret those signals is the key to becoming a strong, proactive advocate for your own reproductive health. You now have the exact medical knowledge to know when to simply observe and when to rush to the emergency room.
Thank you so much for joining us for this explainer today. If you found this breakdown of ovarian cysts and masses clear, helpful, and maybe even a little empowering, please be sure to drop a like on this explainer. And more importantly, share this with the women in your life. This is vital knowledge that every woman and parent absolutely needs to have. Finally, make sure to hit subscribe to the MediByte channel for more expert, visually structured health insights. We are here to make your health make sense. See you next time.